Today, we are going to understand a new module about a geriatric rehabilitation, which is one of the most important and one of the most assessments what we usually miss out in a geriatric population. Today, we are going to focus on the functional training and the mobility part in geriatric rehabilitation. So, anyone, can you tell me what do you understand by this topic or this heading before we go ahead?
It's using those exercises or muscles that we normally use for our everyday routine.
Okay. Anything else? What do you mean by functional training and mobility, first of all?
Focusing on the gait and stability of the patient.
Perfect. One of the very good answers. So, if you want to make the patient functional, first thing we have to always remember the patient should able to sit on his own, stand on his own, and walk on his own. Right? This is a functional movement what we do on regular basis. Okay. Mobility. If you want to move from one place to other place, the only thing what you require is walking, and the walking can be altered in geriatric population because of various reasons and various factors, okay, which we are going to understand in today's module. Is everyone clear? Is everyone with me? Any difficulties yet? Today we are going to understand in detail about the gait training, gait assessment, assistive devices and its assessment, balance and fall prevention strategies, and discussion about each and every topics in detail. Everyone clear? So before going to gait, does anyone know what is gait? How will you define gait? And why it is important for a physical therapist or an occupational therapist to understand gait in a geriatric population? Anyone can answer. Completely fine.
Walking pattern.
Okay, it's a walking pattern, correct. But why it is important for us to understand in a geriatric population?
We need to understand the coordination between the upper and the lower body, ma'am.
Okay, perfect. But why we need to know why it is altered? So if we need to know it, there will be some alteration. Why there is alteration in a geriatric population? The gait, why it is changed?
Mainly due to abnormal gaits.
They could have antalgic gait because of dealing with arthritic conditions.
Superb, yes. So as I had already mentioned, that gait is affected, majorly affected in geriatric population, and there are various reasons. One of is antalgic gait. So, gait training is a form of a physical therapy that helps to improve your walking ability, and it involves a lot of things together. So, whenever a person wants to walk, first of all, it needs lower limb strength. Second, it needs lower limb balance or the body balance. Third, it needs a coordination between upper limb and lower limb. Fourth, it needs good stability. Fifth, it needs good sensation. Okay. If any of these things are impaired or absent, the gait will be affected. Okay. So, what does the gait training do basically? It helps to strengthen the muscle and the joints, improves the balance and the posture, develop the muscle memory, build endurance, retain your legs for repetitive motion, reduce the risk of falls, and increase the mobility. Yes. So these are the advantages of gait training. So before going to the gait training, first we need to understand what is gait and what is a normal gait cycle. So can anyone help me define what is gait?
It's a pattern in how a person normally walks.
Okay, perfect. Anyone else? So basically, It's a one of the important functional mobility which helps the person to transport from one place to another. Okay, so that is called as gait. So in gait we have a gait cycle. So in gait we have two phases. One is stance phase and one is swing phase. Does everyone know gait cycle or do you want me to revise it?
A revision will
Revise
be
it.
better.
Okay. So we have specifically two phases of gait in a gait cycle. One is stance and one is swing phase. So what is stance? Stance is basically when the person's both the legs are in contact with the ground. That's a stance phase. Swing phase means any of one of the legs is in the air, okay, and only one leg is in the contact with the ground. So in stance phase, we have specifically 4 to 5 phases. First is a heel strike, second is toe loading, third is mid stance, and the last phase is terminal stance, and then is a heel off and toe off. In swing phase, specifically, we have something called as uh, initial swing, mid swing, and terminal swing. Every particular phase of gait cycle is very important because any of these phases of the gait cycle can be absent in the individual person, and that phase we have to retrain. Once you start retaining every phase of the gait cycle, entire cycle will be perfect and the person will able to walk well. So always remember that heel strike is basically where the person puts the heel. The rossi flexors and the hip flexors are moving in this particular phase. In loading means your entire body weight comes on one of the legs, which is the first leg what you keep for the cycle. Mid stance means when the body and your leg comes in one line. Terminal stance means when the entire hip goes for extension, and toe off and heel off means when the heel is coming out of the ground to start with the swing phase. In initial phase there will be a little knee flexion where the leg which was in the stance phase now is going for bending to start another gait cycle. So in initial swing there will be little knee bending, in mid swing there will be a mid range of knee bending, and in terminal swing again the same leg will go ahead. So what is the one gate cycle means basically when the first leg, when it is starting from the stance phase, when it comes to the again the stance phase, that is called as one gate cycle. Okay, so there are different components of gate cycle. One is double support means when both the legs are in contact with the ground. Single support means when one leg is in the support of the ground, and double support when specifically when both the legs are working together. So every phase has its double support and single support, and these are the phases what you need to really understand. 60% of our gait cycle consists of stance phase and 40% focuses on the swing phase. Everyone clear the normal gait cycle?
Yes.
Okay. So what are the different types of gaits? First of all, let's discuss that. Does anyone know different types of gates so that we can discuss the gates, the assessment, and how you need to go ahead?
Ma'am, can you please give a revision on that as well?
Okay, so there are different type of gates. First of all, every condition has a different kind of gate. The most common gate what we see is a waddling gait. Where have you seen waddling gait?
In antenatal woman, pregnant woman, ladies.
Okay, that is very nice. Second, the most common condition.
Hip
Osteoarthritis of
extensions.
knee.
Exactly, osteoarthritis of knee. So, osteoarthritis of the knee, the most common gait what we see is a waddling gait. Again, in pregnant women also we see, but that is because of change of posture. Okay, in osteoarthritis of knee, why waddling gait is most common? Because when there is osteoarthritis of knee, there are a lot of bone posture changes. When in the bone posture changes, the most common posture we see at the knee joint is a genu varum. Okay. Whenever there is a genu varum where the knees are facing outwards, the person will walk like a waddling gait. Your toes or your feet will never be in the front. They will always go into extreme toe out position and waddle like a penguin. So that is the most common type of the gait what we see. Second is the circumdatory gait. What is circumdatory gait and where do you see that?
Stroke cases
Exactly, stroke
where
cases.
they, yeah, sorry. So they're
So
unable
circum
to flex, and hence they just use their hip and move the entire leg around, and hence the name.
Perfect, very well. So, why it is happening again in stroke? As you know, the basic knee control and your ankle control is lost. So, what does a person do? It elevates the hip. Okay, it shows a side shift of the hip upward. It goes into the circumdatory gait because the hip flexors and the knee flexion is not working. These muscles are not working because of weakness of the muscles, and that is called as circumdatory. So, every gait has a reason. That reason is what we have to assess, find out, and then start training accordingly. The third most common gait, what we see is a fascinating gait. What is a fascinating gait?
So a person walks in small steps so that they
Hmm.
are able to balance themselves. We see it commonly in Parkinson's.
Perfect, very well. So, in
It's
fascinating
also
gait is a
known as
gait.
shuffling gait.
Also called a shuffling gait. Perfect. So fascinating gait is a gait which is most commonly seen in Parkinson's patient. Why? Because in Parkinson's, as we know, balance and coordination is affected. The person shifts the body weight ahead in order to get the COG very near to the base of support, goes in a very small, takes a very small step. So basically, in such patient, the swing phase is totally absent. Only there is stance phase. Because in stance phase, there is more stability. Always remember. So in fascinating gait, what the person will do, just take very small steps. So your step length and your stride length is also very less as compared to the normal individuals. Is everyone with me? Are you all understanding?
Yes.
Okay,
I'm clear, ma'am.
perfect. So the next is ataxic gait. What is ataxic gait?
Cerebellar gait
Okay, but what does happen in that?
means a person walks like a drunk man.
Okay, very good. How do they walk? Can you explain that?
Unsteady, irregular steps.
Yes, unsteady, irregular steps. There is no proper definition of stride length or swing phase or stance phase. The person is walking crisscross in an abnormal pattern, how you see an alcoholic person walking on a street. Most commonly seen in cerebellar issues. It could be a cerebellar stroke, it could be some cerebellar atrophy, or it could be anything where the cerebellum is affected. Okay. Again, in such patients, the balance and coordination will be lost. What is a spastic gait?
So that's a scissoring gait where the
Yeah.
individual has extreme adductor tightness.
Mhm. Perfect. Where do you see this gait most commonly?
Most commonly,
Cerebral
cerebral
palsy, ma'am.
palsy.
Cerebral palsy. Perfect. Or people who have any spastic diplegia or very tight muscles because of any hydrocephalus or spina bifida, anything. So, any of these conditions are present and the person comes with a spastic gait, it means that there is a lot of adductor tightness. Then next most common gait what we see is an antalgic gait. What is an antalgic gait?
Is seen in arthritic patient.
Okay,
It's basically
very
a
good.
painful gait. Their walk is affected because they are unable to bear weight due to pain.
Exactly. Most common gait what we see in our IPDs or OPDs due to any joint problem or due to any arthritic problem. It could be any joint pain. Imagine I have a low back pain, and because of low back, I have a list on right hand side. Obviously, I will not be able to shift the weight because the person is in so much of pain, and that's why the person comes with an antalgic gait, which is a pain gait. Again, if you remove the pain, the patient will be absolutely all right. So for us, it is very important how to assess the gait, how to find the factors which are contributing, see which muscles are under imbalance, what is the behind reason, and then create a proper plan for gait training. So walking difficulty is the most common problems what we see in an older individuals. It contributes to the loss of independence and which leads to higher rates of morbidity and mortality. Walking is a
Ma'am,
complex task. Yes.
someone in the chat is asked to revise plastic gate, ma'am.
Oh, I'm so sorry. I didn't see into it. Yes, I can definitely revise spastic gait. So spastic gait means imagine a person has a lot of tight adductors. The knees will come closer to each other. Basically, there will be a genu valgum. Both the knees will be touching each other, and the person will walk in a scissor format. Okay, so one leg will come ahead, then the other leg will come ahead. So in that scissoring gait is majorly because of adductor tightness. When there is a too much of adductor tightness, your hip flexors and your knee flexors and knee extensors will not work at its optimum strength, because of which the gait is entirely altered. And at such gait, major problem is which happens in cerebral palsy or people who have spastic muscles of the lower limb. In such patients, balance and coordination is majorly affected. Everyone clear?
Here,
Okay.
ma'am.
So walking is a complex task where we need the demand of the musculoskeletal system, cardiopulmonary system, and nervous system. Typically, the biomechanics are altered. So this is an example what I'm giving for a fascinating gait. So every gait has a deviation in the posture. And that is what we have to assess. So there are biomechanical changes. As you can see in the picture, the flex trunk posture is there, where decreases the hip extension. To the mid to the late stance, there is decrease in the plantar flexion and the power of push off and the movement control is disrupted. Because of this gait, the stride length, the momentum, the time, and the coordination and the rhythm is lost, and the person is hesitant and difficult to transition from the stance to the swing phase because of the balance issues. So these are the biomechanical changes which happens in a fascinating gait. So when you start doing the gait assessment, these are the changes what you have to note, you have to find, and then find the correct answer to it. So, how do we conduct a comprehensive gait assessment? First of all, so there are different components what you have to do in gait assessment. So, before going to the assessment, there are two types of gait assessment. One is objective, one is subjective. Does anyone know which is the subjective and objective gait measurements? Ah, how do we assess? Okay. So subjective is basically it's a very simple thing where you just ask a person to walk multiple times and then assess the gait. Okay. Also, you can just do an observational thing where you take a video, okay, and then you keep seeing the video and see whether what are the changes in the gait. That is a subjective. Every person to person, the subjective gait assessment will change. Which is the objective? Objective means a perfect objective measurement where you have values, where you have meters, where you have distances, where you note which phase is absent. So nowadays there are many AI related assessment apps. There are different apps which are actually made to assess gait, where you just record the video, you put it in that app, and the app will do the work for you. So that is one thing. And the most old school, what we do is we make the patient put the leg inside the ink and ask the patient to walk. And then you start measuring their gait cycle, the gait speed, the stride length, the step length, the velocity, and also the toe out angle. So these are the different assessment tools which you can use according to your clinic availability, according to your knowledge, and according to the patient. So there are the different components what we have to assess. First, always check the gait cycle. What is the patient's gait cycle? Are both the phases of gait cycle present or not? If any of the phases are absent, which phases are absent? Note down the abnormalities and asymmetry. That is the first step. Second step is a gait speed. So gait speed will tell us, and it is a very good, strong predictor about the functional ability and mortality in older adults. Okay, so gait speed has to be noted. How will you assess gait speed? Again, you have to calculate the distance they are walking. You know the time, and you can put the formula and find the speed. Third is balance and coordination. During the gait, you have to see how the person is able to balance, able to coordinate between upper limb and lower limb, because that will tell us the person's risk of fall. Then you have to assess the muscle strength and flexibility. If the muscle strength is good and the flexibility is good, the gait will be perfect. If the person has any difficulty in the joints or the muscles are very tight, that will obviously affect the gait performance. Also, there are different objective assessment and questionnaires also in the market where you assess the gait speed and the types of gait and the balance. The most common is time up and go test, which tells us about the balance and the risk of fall. Second is a gait speed. Third is a dynamic gait index, which tells us a lot components about the gait, its balance and its walking style. And also you can also take Berg's balance scale also if you want. But these are the most three common gait assessment questionnaires what we take in an old age individual. Everyone clear? Any difficulties?
I'm clear.
Okay. So now, before going to the comprehensive gait assessment, there are few things what you have to always do before you go for the gait. First, as the proper medical history, their chief complaints, their HOPI, their surgical history, their past medical history, their current problems. Then go for the physical assessment, specifically on observation, the posture, palpation, examination. In examination, first thing you have to understand, you have to check the musculoskeletal system, higher centers, neurological assessment, balance and coordination. And in the last, you have to check the gait cycle and the speed. Imagine the patient is extremely drowsy, is extremely very lethargic. Such patients, will you check gait? Yes or no?
Yes, ma'am.
You will check gait in such patients. How will you check a gait in a person who is drowsy and lethargic? No, exactly. How will you check, right? If the patient's highest and higher mental functions are only not normal, how will you check gait? It is wrong because if you make the patient walk, or even if you support and make the patient walk, it is not a true gait assessment. Okay, so always make sure if the person's higher mental functions are good, if the person is able to follow your commands, if the person is able to walk on its own, even if it's a wrong gait pattern, it's fine, but they should be able to walk on its own, then only you will go for the functional gait assessment. Clear? Yes or no?
Yes.
After all these things, you have to see which of the components of the gait are absent, and then you have to start with the gait training and gait interventions according to the problem list. Just give me a minute. I hope everyone is clear with this chart, how you have to go ahead. So there are different interventional strategies which are there to train gait. So first of all, it is very important for us to understand what are the factors which because of which the gait is affected. If it is pain, first of all, your important thing is to treat the pain. Second, if it is because of any restricted joints or reduced strength, you have to focus on mobilization and improving the strength. Okay. If you feel the pain of the gait is altered because of some muscle tightness or muscle spasm, you have to release the muscle. You have to make sure that the muscle flexibility is good and then only start with the gait training. If you know the patient is having some spasticity issues because of which the gait is altered, you have to focus on reducing the spasticity, which can be done with the help of neurodynamic techniques or roots approach, which will help to reduce the spastic muscle tone and make sure that the gait is improved. So always find the factors which are making the gait abnormal. After that, when you start treating each and every factors, you have to train the patient for every gait cycle. Imagine the person is coming with a waddling gait where you know the heel strike is only absent and the person is not able to do knee flexion and hip extension. Okay. So in such patients, you have to always start with the first phase of stance phase, which is a heel strike. So you have to keep training the patient to improve the tibialis anterior activation. Okay. Treat the plantar flexion tightness. That's when the heel strike will come. So every phase has to be trained properly. Also, there are many advanced techniques also. First is task specific training, where walking on different surfaces, hurdle training, and stair climbing training will help you to improve the balance and coordination. Perturbation based treadmill, people who have a lot of balance and coordination issues, perturbation will help to create more balance, and that will help to improve the gait. Third is the assistive devices. Patients who feel that they have less muscle strength, or they have undergone some joint replacement surgeries, or have balance issues, you can always give them canes and walkers to make them more dependent and improve their gait pattern. For progression, you can increase the time of the walking distance, the duration, also add complexities and reduce the assistance. So, how can you add complexities? Maybe you can ask them to walk in one straight line. You can give different types of walking, like side walking, cross walking, march walking, lunge walking, walking to make them walk on different surfaces, make them, walk with balancing something in the hand. So, dual tasking training, these are the different progression strategies what you can use to make the patient more aware about the gait, make the patient more independent, and make the patient more mobile. Everyone clear? Any difficulties?
Ma'am, what do you
Yeah.
mean by overground training?
So overground training is basically, if the patient is, I'll give an example. If the patient is a person who is a traffic regulator, the person who manages the traffic, where they have to walk sideways straight, and the person has an ankle fracture or total knee replacement for that matter. So once they are coming to your clinic, you have to train the patient in your clinic, and then train the patient to their actual spot where they are working. So this part is usually done by the occupational therapist, where they usually make the patient do the activity at their own overground, or at their space where they are working, and make sure that they cross the challenges and be better the way they were before. That's called as
Okay,
overground
thank you,
training.
ma'am. Thank
No
you.
problem.
And so it means you're training the person at their site of work.
Exactly. A person who is working in some factories where they have to work for 2 to 3 kilometers at a stretch. You actually
Mm-hmm.
have to train them accordingly. Usually we don't get such geriatric patients, but there are few geriatric patients who tell me that I used to walk 2 kilometers every day, but because of knee pain, I'm not able to walk. So my goal and my job is to make the patient walk for 2 kilometers. That is why he has come to me, right? If I'm not
Mm-hmm.
giving them that strength and I'm not doing that activity for them, it is of no use. So you have
Oh,
to actually make sure that whatever their goals are, you have to achieve that, and make sure that the patient achieves that with you. So that is how the training you have to give them.
okay. Thank you, ma'am.
Yeah, no problem. So this is one of the gate cycle, which and the balance cycle what we give. This is one of the program which I've taken from one of the research papers, where to improve the gait, first we have to focus on balance and mobility. So there are different exercises like single leg stance, heel to toe walk, ankle pumps has to be done. For strength and balance, you can focus on mini squats, step ups, and side step shuffle. Functional and endurance, you can do obstacle walking, straight leg raises, wall and sits circuits. And for progression, you can increase to 20 seconds hold, or add resistance, or add short interval of walk. So this is one of the charts. This is one of the examples of the chart where these are the exercises which are done in order to improve the gait. Clear? Yes.
Clear.
Ma'am, show the previous slide again.
This
Okay.
one.
No, the gate training chart.
So this is one of the examples. You can again curate these chart according to your patient and the problems what they have. So this is specifically for patients who have osteoarthritis, which is again the most common, and that is why I've taken this.
Thank you, ma'am.
No problem. Next, we'll be coming to assisted devices. Now, what is assisted devices and why it is important? I want everyone to answer this because this is very simple.
Assistive devices are like canes, walker, or
Orthosis, prosthesis.
Okay, anything else?
They are
crutches.
important because
Ma'am,
it
what was the
helps
question
a
again?
person maintain balance.
Ma'am, can you repeat the question?
My question is, what is an assistive device? Which are the different types and why do we use in a geriatric population? No problem. So basically, assisted devices is a device, it's an equipment or a gadget or a gizmo that helps to bridge the gap between person's ability to fully walk independently to fulfill their life. Assisted devices can help different people in different ways, but specifically for elderly people, it is a main goal to become more independent and make them do their activities on their own. So what are the different type of assisted devices? So always remember, assisted devices does not only mean wheelchairs, walkers, canes, but there are different assistive devices like communication aids, which is specifically needed for old age people because with age the hearing becomes very slow, the eyes becomes very weak, so you need proper glasses, you need good hearing aids to actually have the proper five senses of our body. Second, mobility aids. Now, what is mobility aids? Canes, walkers, wheelchairs. We are nowadays there are wheel walkers also available in the market. Then is a vision aids, which I've already spoken for vision. Hearing aids, very important. If any of the senses are affected, the person's gait will obviously be affected. Then is cognitive aid. Cognitive aids could be, phones, then alarms, then reminder messages, then GPS systems, then different medical watches. These are the cognitive aids which will help the patient to be more active and make sure that they are assessing themselves on regular basis. So these are the different types of assistive devices. According to your patient, you can choose which assistive devices are required for them and which will help them to become more active. Everyone clear till now?
Ma'am, what is gizmo?
So gizmo is basically it's a just alternative name of gadget. That's all. So these are the different types of assisted devices. Communication devices for people, sometimes they have very lower voices. So there are voice enhancers for walkers, wheelchairs for their musculoskeletal or physical assessment. BiPAP machines for patients who have constant desaturation with the age where lungs are not working properly. Toilet grab bars specifically for patients who have very weak proximal joint muscle where sitting to standing is not possible. So with the help of the gap bars, they can use their upper limb strength to come up or stand. Home adaptations, people who are on wheelchairs, wheelchair bound. There are nowadays wheelchair stairs also where they can just attach their chair and automatically the machine will take them up on the staircase. Adjustable bed where the patient cannot sit on its own. So with the adjustable beds, they can come into the more sitting position from the supine position. Adaptive clothing is also one of the important things because with the age your grip strength, your fine grips, your fingers become very weak. They start having tremors because of which they cannot put small buttons, they cannot pull up the chain. So nowadays velcro straps are readily available in the market, which is very easy for them to stick. Then for cognitive adaptations, TVs, mobiles are there in order to see games or see different serials or something like that, which makes their brain more active, and also see the news. Then nowadays there are wheelchair ramps which are available for the patients to walk over the wheelchair. And nowadays, also for the geriatric population, there are different scooties or vehicles which are adaptive according to the geriatric populations are also available in the market. So these all are assistive technologies which can be used in patient where you feel that they are very dependent, and with the help of these basic assistive devices they can be more independent, they can be more mobile. But you have to choose according to your assessment which assistive devices will work better for them. Clear?
Clear.
Yes, no? Okay.
Yeah, ma'am.
So, just a basic example, if you feel that the person has stroke and is not able to weight shift or is losing balance, you can definitely give them cane on the opposite side. Also, for long-term travels, you can give them wheelchairs. If you know the patient has undergone a recent hip joint replacement, for the gait training, first always start with walker, then you can progress to canes. So, depends on the patient and their problems. You can use the appropriate assistive devices. So this is one thing what you need to understand how we design or how we choose which kind of gait cane or the walker is required. Does a patient need one or both upper limb extremities for weight bearing or balance? So if they need one, okay, what is the frequency of weight bearing? If it's minimal, cane can be given. If it is a lot or if you know that a lot of weight has to be given, so quadruped gait where they have four pods below the cane. If you feel that the both upper limb and lower limb is required for weight bearing, you can always go for wheelchair walkers or proper stable walkers. Okay, so depends on your patient, depends on their balance, depends on their strength. You have to choose whether cane is appropriate or wheelchair or walker is appropriate. Clear? Any difficulties?
Clear.
So, before going to balance and fall, this is what we have already discussed before. I need you to answer. What is balance and how will you assess balance in a geriatric population?
Balance is the ability of one person to maintain their center of gravity within the
Okay,
base of support.
perfect. Very good. And
Observational, subjective and objective markers.
perfect, very good. What is a fall now? What is a fall? Balance is perfectly mentioned. Now, what is fall?
The loss
So,
of
fall,
balance and ability to
it's
keep upright.
exactly. So when a person has a loss of balance, or when the center of gravity is going outside the base of support and the person is not able to balance, that can lead to fall. Balance and fall is a most common symptom what we see in a geriatric population. Again, there are multi factors which are there. So it could be because of musculoskeletal problem like osteoarthritis or pain, or low back pain, or any of the joint or tendon problems. Second, if it's a neurological condition, specifically could be stroke or could be spinal cord injuries, or could be anything when it leads to cerebellar problems or Parkinson's, where the basal ganglia, which is a major balance and coordination area, is affected. That is the thing. Third, it could be cardiopulmonary. Cardiopulmonary specifically balance is not an issue, but if the patient has a lot of fatigue, has a lot of breathlessness, and there is muscle weakness, that can also lead to fall. So every condition has its own reason why the balance is affected and why the fall can happen. So, what are the different strategies? So, our aim is to reduce the balance issues and the fall issues, because more the balance problems, more the falls, more the hospitalization, and very bad, higher chances of morbidity and mortality. And that is what we have to stop as a physical therapist or occupational therapist. Okay. So, first thing, before we go to the treatment options, we have to assess. So, how will you assess fall? As I already mentioned last time also, There are different risk of fall assessment measures like tug, the gait speed. These are the two most common and very easily accessible subjective measures that can be used to understand whether the person is on any medication where they will have a higher risk of fall or not. So these are the ways to understand
Ma'am,
whether
we
the person
cannot
is
hear
at a
you.
higher risk of fall or not. Hello?
But
Ma'am, we
it
cannot hear
wasn't
you.
it wasn't audible.
Hello, am I audible?
What?
Now you
Yes?
are. It wasn't there
Yes.
before.
Okay, no
Few
worries.
seconds back,
Okay.
you're not audible, ma'am. So can you please repeat?
I will repeat. The first thing before going to the treatment, you have to start assessing the fall risk and the balance risk. Okay. For fall, there are different outcome measures which are available in the market, like tug and gait speed. For balance issues, how will you assess? Berg balance scale, dynamic gait index scale. These are the scales which are available in the market to see the balance issues in geriatric population. Then is a medication review. You have to always check whether the person is on any medication where they will have any influence on the higher centers where the patient is constantly drowsy and can lose balance. Third is exercise programs. So you have to always check whether the person is on any exercise program or not. If they are or not, you have to immediately start strengthening and improving the balance and coordination. Safe footwear. Always choose the footwear, always check the footwear, which kind of footwear are they wearing, which have a good ankle support or foot support. Are they slippery or non-slippery? Second is a clutter removal. Any of the so whenever you go to assess their house, wherever they are staying, or the community where they are staying, you have to always check the flooring. You have to check the lighting. You have to check the different types of the thresholds which are there. Are there any grab bars or supports which are available in order to see? Okay. Then is always check the lighting. If there is any lighting issues, you have to immediately change that. Helpful devices. If any grab bars are there or walking aids are available. Bathroom safety. Majorly the falls happen in the bathroom due to the wetness. So always see whether the bathroom is constantly dried and the bathroom has grab bars. Even if it is wet, the patient should able to hold on to something. Bedroom changes. So in bedroom specifically, the patients when they are walking inside the bedroom, you have to see whether the sleeping space on the mattress where they are sleeping is at which height. Is it at a low height or higher height? And is it near to the bathroom or not? Kitchen updates. If the kitchen stools or the storages are very high or it is extremely very low, the patient has to go outside the base of support to do the particular activity. So make sure that everything is at the shoulder level reach so that the patient can easily take without losing the balance. Stair safety is very important. Add railing and also should have better visibility and better lighting. So these are the assessment charts what you have to do before going to the strategies. Everyone clear?
Yes.
Clear,
Okay.
ma'am.
Okay. So, what kind of strategies, what you will start updating in order to improve the balance and falls? I want everyone to answer each in each strategies.
Ma'am, please repeat the question.
Everyone, I need every person to tell one strategy to improve balance and fall in an older individual. What treatment strategies, what you use? Can anyone tell?
Exercise and strength training specifically to the relevant areas for each individual.
Perfect. Strength training is one of the examples, specifically targeting the proximal muscles, which is the most common thing. If your proximal muscles are good, your core, back, your glutes maximus, your spinal muscles are strong, it is very easy for you to start balancing. Yes, that is the first thing. Second,
Obstacle training, like go through an obstacle course or something.
okay, that perturbation training, obstacle. Yes, obstacle training basically helps to create and shift the weight and improve the balance. Second is perturbation training, yes, but different strategies like ankle strategies, hip strategy and spinal strategies usually work together in order to improve the balance and reduce the fall. Yes. Anyone else? Be more creative. What are the different techniques more you use?
Assessment of like vision and their vestibular function. How will we do that? Do we have to do it, or someone we have to refer them to someone?
You can definitely do the vision, right? You can obviously, as we know, you just have to do the high mental function assessment where cranial nerves. For cranial nerve, you just have to assess the cranial nerves, right? Three, four, six.
Mm.
These cranial nerves, if you assess, you check their eye movements, you see, and you ask the history of any giddiness is present or not. If you feel that the person might have vertigo, you have to immediately send the patient to ENT. If you feel during the higher mental function evaluation that the cranial nerves are fine, then you can definitely go ahead and always ask
Mm.
them about their numbers, because some patients have both number, rare vision, also near vision. You have to ask
Right.
them, are you taking the number properly assessing in every 3 months, because with age there are a lot of changes of the eye numbers which happens.
Right.
Okay, so this has to be done. That this
Mm.
treatment is not in our hand, but yes, you can definitely ask them to check their number and make
Right.
sure that they don't have any vertigo problems. Frankel's
Right. So for
exercise.
that, yeah, Epley's manual test for assessing also can be done for them.
Yes, you can definitely go ahead to rule out vertigo in such patients. Frankel's exercise is one of the very good balance exercises and coordination exercises which you can do in the geriatric population. Always start with um, smaller movements, then go to the larger movements. Always start with the slower speed, then go to the faster speed, according to the Frankel's exercises. With the progression, you can also start with a medicine ball or the exercise ball. Balance board exercises again depends on the patient's strength, patient's condition. So these are the different interventional strategies which you can use in order to improve their balance. Once the balance is better, once the coordination is better, the fall will never happen. Clear?
Clear.
And there is one square stepping exercise for
I
balance
can
and improve fall.
I cannot hear you. What?
Square stepping exercise to improve balance and prevent fall by Shigematsu Okura.
Perfect. That is also one of the good exercises what you can use. Also, there is one domain of exercise which is called as Tai Chi. It's a Chinese medicine exercise, which is very excellent exercise to improve your movement flow, improve your flexibility, improve your balance. If you start doing this few Tai Chi based exercises in such patients, definitely the balance will get better. To train balance, it takes a longer time. So you have to always take minimum 2 to 3 months of training before improving the balance. Because there are a lot of things. From day one only, we will not start with balance board or medicine ball exercises, right? We have to assess their levels and then go slowly, 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 slowly increasing. Clear?
Yes, ma'am.
Ma'am, even
Clear.
transfer exercises also to improve functional independence.
Which exercise? I'm sorry.
Transferring exercises.
Yeah, transference exercise. Okay, this is also one of the balance exercises, but these exercises usually start at a early stage where the person is not able to sit. You have to train them in sitting first. If you then you have to focus from sit to stand, then you have to focus on stand to walk, then you have to focus on walking. So this is how you keep improve. First of all, always important, you have to first train the patient functionally. When the patient is fully trained functionally, as the patient is able to walk independently or with the help of cane or any assisted device, then only start with these advanced balance exercises. Before that, you will not. Because that again, if there is fall, these patients are already osteoporotic and have sarcopenia that can immediately lead to fractures. Again, not everyone, but majority patients, if they have fall, can lead to fractures. Everyone clear? Any difficulties?
Clear.
Okay. Thank you so much for attending today evening session. I hope it was clear, easy to understand. Start reading if you have any doubts and difficulties. Do come back to me. Thank you.